We are your hosts, Nikki Shore and Jesse Swain, and you are listening to the American Journal of Infection Control podcast, Science into Practice, brought to you by the Association for Professionals in Infection Control and Epidemiology to highlight work published in our peer-reviewed journal, ACHIC.
Join us as we speak to those in the field of infection prevention and control, like us, as well as other experts, to learn about some of the latest research in the field and how it can be put into practice. We hope you will listen in, learn something new, and apply this information to your work. If you are not a researcher already, we hope this podcast will get you thinking about areas where you can carry out your own research.
Hey, Jesse, how are you?
Excellent. How are you?
I'm good. You know, this show is supposed to be evergreen, so we're not supposed to talk about it. But it's so hot outside.
Yeah, it is. It's been pretty horrendous the last few days.
I will tell you what was apparently super hot was the recent APIC National Conference, which, Jesse, you got to go to. How was it?
It was fantastic. Lots of great talks from lots of wonderful people, able to make some great connections with people from my region, but also people around the world. So it's a lot of fun. It's a lot of networking, and it's a lot of things to learn about from others. So it's great.
Indeed. Fantastic. I was a little jealous of you for being able to go, but I was out because I had a procedure during that time. And I'll tell you something really concerning that happened. Right before the surgery, the surgeon said, "Relax, Lisa. It's just a small scalpel incision. No reason to panic." And I was like, "Well, that's great, doctor, but my name isn't Lisa." And she said, I know, I'm Lisa."
Well, that's a little disconcerting.
I was actually not at APIC because I was on a beach vacation, not because I had the procedure. But the reason I made that joke is because today's episode takes place in the operating room. So we are going to be talking to Heather Dixon, Mathea Schafer, and Dr. Mohamed Yassin about their article, Automated Traffic Monitoring of Neurosurgical Operating Room. So Heather Dixon is the Director of Quality, Safety, and Infection Prevention at the University of Pittsburgh Medical Center, Mercy in Pittsburgh, Pennsylvania. She received her BSN from Franciscan University and MSN from Waynesburg University. Ms. Dixon is a member of the Certification Board of Infection Control and Epidemiology CBIC Test Committee and APIC. She began her career as a nurse leader and progressed into healthcare quality, and she now oversees the hospital's quality program, including infection prevention, patient safety, experience, and regulatory programs, leading a team of 20 professionals. Under her leadership, the hospital earned a Leapfrog Safety Grade A from 2019 to 2021. She has developed mentoring models for nursing and public health students, is a site director and a course instructor for the University of Pittsburgh School of Public Health, and has published works on healthcare quality, infection prevention, and mentorship. Mathea Schafer, MPH, graduated in 2021 from Creighton University with a Bachelor of Science in Neuroscience, with minors in biology and public health. Originally from Nebraska, she moved to Pittsburgh to pursue her graduate studies at the University of Pittsburgh. At the School of Public Health, she earned her Master's of Public Health in Infectious Disease and Microbiology, concentrating on pathogenesis, eradication, and laboratory practices. In 2022, Mathea began working at UPMC Mercy as a student in infection prevention, conducting her thesis research on infection prevention during surgical procedures in the operating rooms. After obtaining her MPH, she joined UPMC Mercy as an infection preventionist, focusing on surgical areas and high-level disinfection. Dr. Mohamed Yassin is an infectious diseases physician who graduated with honors from Cairo University School of Medicine. He completed his residency at Michigan State University and his infectious diseases fellowship at Case Western Reserve University. With over 10 years of experience in infection prevention and hospital epidemiology, Dr. Yassin has a special interest in endoscope disinfection, burn infections, and various hospital-associated infections. He has authored over 200 manuscripts and scientific abstracts and has delivered numerous scientific presentations at the APIC National Conference and other national and international conferences. Go Spartans. So welcome, guys. We're happy to have you.
Thank you.
go ahead and kick us off and tell us what prompted your study?
Well, surgical site infection is one of the most painful things that a person could have. You expect to feel better after your surgery. You don't want to get another complication. We always look for a lot of things related to surgery as far as prevention, but we don't look into the OR itself that much. So we really were interested in making sure that the OR or the operation room is a sacred place with the utmost quality of traffic behavior to make sure that the patient has the safest possible experience and the lowest risk for infection.
Yeah, SSIs are very critical. I agree with that. And it's a cool project that you guys did because you had a threefold approach. You had some automated traffic monitoring using something called the Pearl wireless people counter. And you also did direct observations and staff interviews. So can you tell us a little bit more about what that looked like?
Perfect. Yes, of course. Thank you so much. So for our first option, we did the direct observations was our first section. We did 10 hours of observation just outside the OR in increments of these neurosurgical procedures, looking for things like how many times people entered or exited, and what they were doing, if they were bringing equipment in or other supplies in, as well as just the length of procedure as well. So all that was documented in the direct observations. We then moved on to a longer section where we observed 100 procedures with an automated device that we repurposed from the retail store side for our indirect observations, where we did also include neurosurgical procedures where we include the entire procedure and how many times people entered in or out of during those procedures. We then followed that up with the kind of why are staff doing this, including the staff members and what they think of what's going on. So interviewed a whole bunch of staff members, with included like surgeons, nurses, techs. Housekeeping was also included in those staff interviews, and kind of what their observations of what OR traffic was.
Okay, so I have to ask, where did you get the idea to repurpose this device to use to do the in and out counts?
I wanted to ask this too.
The idea behind the automated monitors were actually published previously before, and we're always in the look for an objective way as we do our business in infection prevention. We always say, if we don't have a documentation, then it's not done. So we were always looking for a way to actually show how exactly people going in and out, what's the pattern. And as my colleague, Mathea Schafer, was just saying, it's very hard to do direct observation for 500 hours. That's really hard. But with these automated monitors, you can actually do limitless amount of observation. So we were looking for these kind of monitors. We talked to multiple companies till we find something that could fit our interest as operation room monitoring.
That's
awesome. Innovative. Yes. Yeah. You're an innovator. Team innovation.
So this study in particular was looking at neurosurgeries. As you move through this research project, did you identify any other types of surgeries that might be likely to have these higher level of interruptions?
So a lot of our procedures that have implants have a higher risk because they're longer and there's a lot more people involved in those procedures. Of course, those have a higher risk of surgical site infections as well. And so those are super important for looking at all of our ways to prevent infections in those cases as well.
How did you exclude influencing factors like equipment that may have crossed the path of the sensor, hesitation of staff at the door, or people potentially leaving notes on the door from the total numbers of folks coming in and out?
We actually didn't end up in the end excluding all of those because they happened so infrequently when we observed the OR door themselves. They barely affected the end number total overall, as well as the aggregate of the 100 procedures we did observe with those online monitoring. So we didn't end up excluding those at all.
Interesting. Thank you.
And you included a wide variety of staff in your interviews, including surgeons, RNs, techs, vendors, housekeeping. Did you get a feel that maybe one area had a more accurate observation than others, more accurate reporting?
Yeah, of course. Some people seem more observant than others, but our nursing leadership is always fantastic, and they are super on point. While not as high as what we observed, they were significantly higher than all the other staff types we interviewed when they estimated how many people entered or exited per hour.
So they were more accurate with their reporting observations?
Yes, yeah. I think they all have an opportunity to see how many people go in and out more than the people actually in the OR, because they're roaming about in the hallways, they're talking to staff more often. So they have that opportunity to see traffic.
Interesting. That's interesting. Did you get a sense that most of all of the staff was aware of the infection prevention and patient safety implications of increased OR traffic?
Yeah, the OR staff are always very knowledgeable on how they can prevent infections, especially in this really critical period where a patient is having a surgery. So they were all aware of it. To the degree it's not always front of mind. It's like the basics for them.
And sometimes there was more than one person that entered or exited the room at the same time. And does that mean that the time that the door was open was increased? And would that then potentially increase the microbial count?
Yeah, of course. If two people aren't going right behind each other out the door can be open longer. And that can definitely influence risk for infection as well.
Any thoughts on the number of people in the room during the procedure with regard to risk of SSI, or even the movement of the people that are already in the room, like as the procedure is taking place? Do you think that either of those two things increases the risk of SSI as well?
Yes, we agree with you on that for sure. The more number of people in the room, the more they're moving, the more chance for contamination or for issues related to surgical site infection. So a famous surgeon with 5 people observing his procedure to learn is a higher risk than one surgeon by himself doing the procedure. You are right, spot on for sure. Yes.
Yeah, that question, I actually thought of that because coming from an academic medical center, we hear this a lot, that we have a lot of people in the room. And I've always wondered if if that really is a risk factor. But again, then there's the argument that if you're a learning facility, then what do you do? When you want to teach people, you need them in the room to observe. So it's kind of like that catch-22.
You are right, spot on. We had this famous surgeon who passed away. He used to be specialized in a specific procedure for the knee, and he would have all these presidents and kings and famous players coming to his sports center to do the procedure, and you could see the room full of trainees and different level of providers. And for me, as an infection prevention specialist, this is a nightmare. Absolutely, you're right, spot on.
Yeah, I can imagine hearing that and just cringing a little bit. And, I was surprised when I read in the article that people were opening the door to perform hand hygiene. I was a little confused by that. Are they stepping out to scrub again mid-procedure, or what was that about?
I can talk about one particular instance where I saw this, where the person went into the OR, checked in, and then came back out to perform a scrub and then entered again. There is hand sanitizer available in the OR for people to perform hand hygiene inside, but they cannot scrub inside the OR, so they have to do that.
Yeah, I was curious as to why that happened. So did that happen a lot?
It did not happen often. No, it was just an occasional thing that happened. But it did happen. It does happen.
So I also read in there that 59% of the observations were not linked to any discernible task. And I thought that was surprising. So can you comment on that, or was the staff able to comment on that?
Yeah, so when in the interviews, I particularly asked about this because I was curious. So they mostly told me that they go in to check on their staff members, deliver medication, answer questions, teach, as we previously talked about, is very important. So they do enter to do that option, which I can't quite discern from the people entering for other tasks. They don't have something physically in their hands.
Yeah, I also find that interesting. And probably to our previous point about having people in the room, I have observed some cases in my IEP role in the past. And during one of the cases, a resident actually came in and the surgeon was asked like why they had come in, and they were like, "Oh, I'm just checking in." And so I was like, in my mind in that moment, I'm like, why are they here? Why are they in this room? But I think it does definitely happen. So some doors, and I've heard of this in the past as well, are preferred over others for coming in and out, specifically the one that's closest to the scrub sink. Was this because the staff were stepping out to perform hand hygiene, as mentioned before, or do you think it's just the proximity of the sink to the OR as they're scrubbing and coming in?
So in this particular OR, the side door, which we instruct people to use, we're actually the closer one to the sink, but there's no really continuity to it. So even if we think about a splash or anything from the sink or the drain, we cannot imagine that this goes into the OR area for sure. We instruct people not to use the main door, except if you have a big equipment that cannot go through any other door, or the patient himself going in and out of the OR. Everybody else should use the side door to really minimize the disturbance of the air flow and the exchanges and so on.
So you don't think that the specific door in proximity to anything really impacts the microbial count? So just because that door is next to the sink doesn't really mean that that's increasing the microbial count?
Again, yes, the OR designs could be a little bit different from hospital to hospital. And I have a vision of the OR that we're talking about in my head, but you don't have that, or anybody can see that. So theoretically speaking, what you're saying could be true, but in our case, the sinks are really not an influence at all to the OR itself.
Okay.
What about the number of air changes in the room? Could that impact the risk of contamination? So some having more than others. What are your thoughts on that?
So the air changes are a set number that is regulated, and they happen every time, very quickly. Every like 4 seconds, there's a brand new air in the OR. So that is an influence, but it's really important, but it doesn't really change how many people go in and out.
The hospital end up implementing any improvements because of this? Any bundles or checklists for evaluating supplies needed for procedures, coordinating breaks, communication, et cetera?
Yeah, of course. So they're currently working on reevaluating our pick lists for what actually gets brought into the OR before the case starts. So they have what they need in there already. They've also done some more evaluation on what the tasks are and how they can improve that. So that our nursing and OR leadership has really taken that on and really dedicated themselves to reducing OR traffic.
And to expand on that a little bit, the article was saying that staff that was interviewed, they suggested different ways of communication, like using the phones in the rooms. Do you know if those are landlines, or are they talking about using cell phones? And if so, I mean, I'm thinking of so many different implications that has, like, if you've got a cell phone that has to either stay in the OR and it has to be disinfected properly. And it's interesting because the staff had very good, it seems, robust ideas on how to decrease traffic. So I'm curious about whether you implemented that and some of the intricacies and nuances that come with those interventions.
Yeah, so they suggested the phones in particular because it's already existing infrastructure. The phones already exist in the ORs and they're already regularly cleaned as part of the OR cleaning process for turnover. So it would just be something that they could utilize more frequently than they currently do, as a suggestion that they suggested.
That's great. And then one of the other quotes from the article that we were hoping maybe you could expand a little bit on was, knowledge and awareness gaps were also discovered during the interviews. What kinds of knowledge gaps and awareness gaps did you note from the staff?
So I think it was more like the awareness of what is going on, like the big picture. The staff are excellent at their jobs. They do their jobs very well, but sometimes they don't see the entire picture of what everyone's doing because they're focused on their job and do it so well. So that's where they don't quite see the large picture. That's where the awareness gaps were kind of.
And so that's where
awareness.
I see what you're saying. Like, Okay, so this is going on, and all of these entrances are going to affect infection control. That's not in their larger schema. They're focused on making sure that scalpel, stat, etc. I see what you're saying. Right? Is that what you're saying?
Yeah, I can see how that would be. You have your one focus while you're in the room, the patient, and doing that surgery. So maybe the door opening and closing isn't the most important thing on your mind. But the conclusion seems to imply that a combination of direct and automated direct observations would significantly decrease OR traffic. Any suggestions on how hospitals could best implement this?
I think a great way to utilize both those two observation methods together would be to use the automated method to track trends over time, and then do the direct method to figure out what the issue is, or like, why is this trend happening? So then you can specifically address what is happening and how we can improve that specific measure. We see that happening over time.
That's great.
Best of both worlds a little bit there.
It's a really neat read, because I was surprised at some of it. Like Jess said, I've done my fair share of observing in an OR, and my bigger picture is infection prevention. So like you said, that's not everybody else's bigger picture. So all of our big pictures might be a little different. I found it surprising to read something like 59% of all of the entries were for no discernible task, and that people, to hear you say that people are just checking in, that to me is very surprising, because in my head, like, come on, this is infection prevention. You want to decrease these entrances and door openings. So it's helpful from our point of view to read that, to remember that infection prevention is a constant reminder, So what are some of the takeaways that you have for the listeners?
I think we have a lot of takeaway from this work, and I don't think it's the end. I think there's more to come. But first thing in my mind was the surgeon themselves expressed a lot of interest in actually having those automated monitors for all the operation rooms. Neurosurgery, vascular surgery, orthopedic surgery, all the implant, longer surgery, they feel this should be part of their OR safety. Mm-hmm. And the OR teams are actually buying into this, and we're looking into that further. I think when people know or see, they're starting getting into doing things more consistently, not trying to make advertisement for Apple Watch, but when you have some sort of something to see how many steps you do, you start getting into the habit of being active. So I think we don't know what we don't know. When we see how much traffic, then we say this is unacceptable, we have to really reduce that. And when we have a consistent way of seeing that, this helps. The manual or the direct observation is absolutely irreplaceable. You really cannot get enough information without visually seeing and observing what is actually happening. And we think a combination of both is very beneficial, but you really cannot do direct observation for this many hours. That's really very hard and labor intensive. So we think automated would be a very good way with some direct observation to make sure that what you're seeing is accurate and to the point.
Yes, you can't make any changes without the data, and you can't have enough data points on something like this because there are so many hours in the OR room. You can't really dedicate one person to just doing observations for several different procedures. So I loved the article. I thought it was a great read.
Well, thank you all so much for joining us today. This was a lot of fun. And I think, as always, Nikki and I enjoy the conversation, but we also enjoy learning from you. And we love the research that you're doing. And we hope that you'll continue to do more, and we'll hear from you again.
We're happy to answer any questions anytime. Thank you.
All right. We'll put on your personal cell phone numbers and let people text you any time of night. Just kidding. Thank you guys for joining. Everybody have a great week. That's a wrap. Thank you for joining us today. We are Nikki Shore and Jesse Swain, and this is the American Journal of Infection Control podcast, Science into Practice. Thanks for listening and doing your part to prevent infection, because remember, infection prevention is everybody's business.
AGIC Science into Practice is created by the Association for Professionals in Infection Control and Epidemiology with input from the APIC Center of Research, Practice, and Innovation, and Pat Stone and Jean Brandt at AGIC and APIC staff, Rebecca Bartles, Ria Gupta, Bobby Gulshan, and Liz Garman. We work in partnership with Human Factor and audio techs Blake Alton and Carolyn Schneer. To hear other AGIC episodes and to access information about this podcast and the field of infection prevention and control, go to our website, agicscienceintopractice.org. That's AJIC scienceintopractice.org.